Alright, this lecture is on gastric acid suppression. We're going to talk primarily about two classes of drugs here, proton pump inhibitors and histamine 2 receptor antagonists. So a little quick background. Human stomach contains 1 billion parietal cells that secrete hydrochloric acid, and these are all pretty much regulated by three systems, or three, what do you want to call it, neurocrine transmitters. So you have acetylcholine, histamine, and gastrin that all play a role. And the major drug that's going to affect any of these systems is going to be affecting histamine. There's specific histamine 2 receptors in the parietal cell membrane that are different than the receptors that are designed to promote histamine response that causes itching that we think of with allergies. So again, histamine 1 is more that particular type, and that's something that like a drug like Benadryl would target, whereas histamine 2 is going to be more specific to the stomach. Gastrin is there, it's important, but we don't use it pharmacologically, and we don't really do anything with acetylcholine from a pharmacologic perspective. This is just a drawing that kind of illustrates what I said. This drawing I like a little bit better because it's boxes and it's simple. Kind of shows you here's your stomach lining and your proton pump, which is your final step here, and releasing hydrochloric acid, and here are the different mechanisms that are manipulating it. So you can see the histamine mechanism is a little bit more downstream, whereas our proton pump inhibitors work directly on the final step. So some background, histamine appears to be the most prominent mechanism involved, and so that's why the drugs we use really focus on that, or they focus on blocking the actual hydrogen-potassium ATPase on the surface of the parietal cell, which is your final pathway. So those seem to be the two most effective ways of, and easy enough ways, actually, from a mechanism point of view. They're pretty simple ways of blocking the parietal cells from producing acid. They're basically used interchangeably to a certain degree. As far as generalizations, PPIs are the newer agent, but they've been established as being more effective and are usually, well, we'll talk about the differences as we go through them as opposed to me just talking right now. We'll organize it a little better here. So let's start with proton pump inhibitors. So these are our most potent agents. They're most effective when taken before breakfast because they only inhibit activated ATPase. So you want to get the drug into the system. It's important to understand that proton pump inhibitors don't work in the stomach. They work by getting absorbed, and then they go systemically and kind of approach. You want to think about it. They get absorbed in the bloodstream, and then they end up interacting with the parietal cell via systemic circulation, not because they touch them in the stomach. So they're actually these products are actually delayed or extended release in order to get through the stomach, get absorbed, and the idea is you get them absorbed in 20-30 minutes after taking it, and then you eat a meal and your ATPase is activated, and then the drug will work on the specific areas. Most people take them once daily, and somebody who takes a drug once daily inhibits acid output by about 66% after 5 days, which is usually enough to decrease symptoms of Gerd or heartburn. PRN usage is not recommended or reliable with proton pump inhibitors. Doesn't mean you won't see people who say, oh, I just kind of take that when I need it. They just don't work that quickly, so you usually need a few days to see the full effects from them. Would you get effects after 1 day? Potentially, but would you get effects after 30 minutes? No. So they aren't a fast-acting product, and that's probably their biggest difference from H2 blockers. More effective, slower acting. Sometimes BID dosing is used. However, sustained BID dosing is questionable. You'd really only use twice daily dosing in certain situations, more severe situations, like gastric ulcers or treating H. pylori infections or something like that. But most people will take it once a day. If you stop the drug, you'd have some continued effects for 2 days after, so it does last a little bit. However, you can also get rebound heartburn after those couple days are over, and then have some pretty significant symptoms from that. There's a few different options on the market. Essentially, they're all the same. And the nice thing is all their names sound the same too. So if you know the Prazols, you know it's a PPI, and they're all Me Too drugs. There's not one that's better than the other. There are some comparisons and small differences reported, but nothing is really clinically significant. So how do we decide? Basically cost. Some of these are over the counter now. In fact, a lot of them are. But for the most part, it will dictate the way insurance says you should prescribe them. So I'll come back to this selection in a second, but as an example, pantoprazole is not over the counter. It's not brand name either. For some reason, it's still prescription only, but that might be one that, like, if the patient was saying they're having an issue affording over-the-counter omeprazole, you could maybe prescribe pantoprazole and maybe their insurance would pay for it. Or the insurance might come back and say, no, we don't cover pantoprazole. We want the patient to pay out of pocket for OTC. It's kind of a weird thing if you didn't know this, and I haven't really talked about it, but most over-the-counter medications aren't covered by insurance. Even though they're cheap, relatively speaking, to a lot of their prescription counterparts, insurances will usually say, well, over-the-counter things aren't really that essential for the health of my patient I'm covering, so, let's just make them pay for it. If you want it, great, but buy it yourself. It's a lot of the times what you might see. This is a chart that I don't want you to memorize, but I get this question a lot in practice and how to convert PPIs one to the other. There isn't a great conversion, but the nice thing is that esomeprazole, omeprazole, and pantoprazole are all the same dose, and those are some of the more common ones. Lansoprazole is just a little bit less, and then dexlansoprazole is a newer one. Rabeprazole is almost never used, so we don't really think about those too much. Prilosec, Prevacid, and Nexium are all over the counter now, and again, pantoprazole is still still prescription only. And dexlansoprazole is a newer med that's prescription only. Omeprazole or Prilosec was the first one to market. It's the first one to go over the counter and generic too, which meant that everyone was taking it. It's still probably the more common one. The other ones, again, are all pretty much interchangeable. Rabeprazole, for whatever reason, has been kind of expensive, even though it's gone generic, and it's the least used one that I've seen. Whether that means anything or not, I don't know, but it's just not very common. I don't think a lot of insurances are paying for it, and at this point, people just would start them on a more commonly known drug. Lansoprazole is, again, no different than really any of the other ones. The one thing to know, not for an exam, but just for real life, lansoprazole comes as an orally dissolving formulation, which is a nice advantage because you can mix it with like liquid and take it. So for products, if we have a patient who's NPO or has an NG tube, that's a really nice way to mix it up in some water and throw it down the tube. The PrevPak is a combination product that has lansoprazole and clarithromycin and amoxicillin in it. And it's designed as a H. pylori packet. It's kind of overpriced for what it is. I don't even know if they make it anymore, but it was something out there. And pantoprazole we talked about. Pantoprazole and esomeprazole come as IV too, which is really advantageous for people who have really severe GI issues where you want to lower the acid production quite quickly, and I'll talk about that in a couple slides here. Interactions. These may interfere with some medications, but clinically significant, we don't really know. Most are CYP metabolized. Plasma concentrations are variable in a lot of different ethnic groups depending on their metabolism, whether they're hyper or hypo metabolizers. So if you are concerned about drug interactions, the moral of the story is that pantoprazole probably has the lowest risk of causing CYP-related interactions and problems. Most interactions that have been found with PPIs aren't supposedly clinically relevant. I think I talked about the clopidogrel fiasco last fall and how everyone was scared that the interaction with omeprazole and clopidogrel wasn't causing the prodrug to be able to convert correctly, so the overall clinical impact would have been diminished, but actually we found out that it didn't really matter over time. Also, one thing just to keep in the back of your mind is by suppressing the body's ability to make stomach acid, you have potentially drug absorption or breakdown issues that you might not otherwise know about. That would be odd, and you don't really need to think about that too hard, but it's just something to consider. There might be certain things that are more sensitive to that. And if you work in like transplant or HIV medicine or oncology, that may be where your oral absorption is super important, and you want to make sure you aren't diminishing it if it needs an acidic environment. PPI safety, so these have gone over the counter, which probably means that most people think that they're safe, and they are pretty safe, but if you also look at the way that they're recommended you take them, it doesn't recommend using them for more than 14 days. So interestingly enough, when you take PPIs for really long term, you end up increasing your enteric infection risk. And one of the most common things that people see, so the reason behind this is because your body's defense mechanism, your stomach acid, kills bacteria. If you remove that, it's not a huge deal for our developed countries where we have pretty good control of our food supply chain, but certainly stuff like C. diff rate, has gone up substantially and is correlated to people using PPIs. In fact, there's some incidents of PPI use and C. diff occurrence without even antibiotic involved, just simply they acquired it in the community somehow. And the incidence is quite a bit higher with PPI use than with H2 blockers. So this is probably the one reason why I always recommend if somebody takes a PPI regularly to question it a little bit and just make sure they have an actual indication for it, because they're probably, while we perceive them as safe, and they are pretty safe medications, they aren't without risks completely. And I do think in some cases the risks do outweigh the benefits of these drugs, especially if you're going to take them regularly. Pneumonia, I'm not going to talk about unless it's very small, not associated with increased hospitalizations, possibly having to do with colonization in the upper GI tract. Malabsorption, talked about this a little bit with drugs. It can also happen with vitamin B12 and iron, probably not, again, not clinically significant. Higher hip fracture, calcium absorption, hypomagnesia, again, all this shows some correlation, but probably not super relevant. There was some thoughts that PPIs might cause increased tumor risk because they have higher gastrin levels, and this hasn't been really seen in humans though, just in rats. So switching gears here to H2 blockers, the big difference is here they work much faster than proton pump inhibitors, so you can actually take an H2 blocker as needed. These are the drugs to recommend to people if they have occasional heartburn. I think people either see commercials or they see Prilosec on the shelf or whatever it might be, and they decide to buy it because they've heard it works or whatever. It's really not a great option for somebody who gets heartburn once a month or twice a month. This is probably the better option. One, it works fast, and two, it's got a decent duration. It's going to stay in the system for a while, unlike Tums or some of the antacids, which we'll talk about here in a second, that have much shorter durations, and you have to take them repeatedly. These medications just seem to be much better for that purpose. They are less potent, so you don't get quite the good acid suppression, but it's still pretty comparable, and they are thought to be a decent alternative to a PPI. They do carry similar risks and similar side effects, so the enteric stuff is prevalent here, or is present here, but we don't consider it as bad as with the PPI. They're all over the counter. They all have prescription strengths available as well. Possible complications, not too much, to be honest. There's not really anything that happens with these drugs unless you take them excessively or you have poor kidney function that causes you not to be able to eliminate them. That's where you might see the CNS related effects. There's 3 drugs available. There's famotidine, ranitidine, and cimetidine. Famotidine is probably going to be the most common one you see. Ranitidine there's no reason not to use it. The thing about ranitidine, you may have heard about this, is ranitidine is getting recalled regularly now. That's because there's been some issues with the way the products have been formulated that contain a carcinogen, which is always great to hear, especially if the kind of kicker to this one is that ranitidine is the best studied antacid in pregnancy, and so it's commonly used in pregnant patients and recommended over famotidine, and I think we're going to see that change pretty quickly. In fact, we can't even get ranitidine in anymore in the hospital. We're completely out of it because of all the market withdrawal. So famotidine is the product we generally use, but we keep a little bit of ranitidine on hand, especially for our OB areas, and that's probably going to be changing soon, I would imagine. Cimetidine was the least used of these, and it has a lot of side effects, has drug interactions, and again, I don't recommend using this. I would just use famotidine. There's really no issue why you couldn't. And yes, even though we know that ranitidine is probably safe in pregnancy, famotidine hasn't been as well studied, it's probably fine. There's probably no reason why you couldn't do it, and there's no clinical difference between them. So they are dosed twice daily versus PPIs generally once daily, so they don't last quite as long. Some other things to think about: antacids just neutralize gastric acid on contact temporarily, so usually going to be calcium carbonate products like Tums. Magnesium products, aluminum products, those are kind of the different brand names out there that you've probably heard of. These are usually repeatedly dosed every few hours. They don't provide good sustained effects, and again, somebody might find them relieving for a certain time. Sometimes people will say, well, if somebody gets kind of mild heartburn throughout the day and they need calcium supplement, maybe Tums is a good option, and sure, I wouldn't argue with that, but I do think that these are weaker compared to their H2 counterparts. Sulcrophate or caraphate is a polysaccharide. It basically coats injured gastric tissue and kind of covers up the ulcer and helps it heal. So you might see this used in patients who have active ulcerations. Pepto, we talked about this, doesn't really alter gastric acid, but it does suppress H. pylori function a little bit, and so that can help with that particular component. Otherwise, that's pretty much it. So talking about GERD really quickly. So GERD is gastroesophageal reflux disease, aka heartburn. Treatment basis, frequency and severity of symptoms is something we want to assess. Remember, do they get heartburn once a month? Do they get it every day? Is it to the point where it's erosive esophagitis? Is it more severe? Something we need to refer them to a specialist for. Lifestyle and dietary changes can be effective. Weight loss can be effective. Elevating the head of the bed is an interesting, easy strategy for a lot of patients. Simple gravity, by not allowing your body to sit in a way that allows gastric acid to constantly push on the various sphincters that control the stomach contents, you can end up with improving symptoms that way. So one thing I've heard, people put like a big book under each, or cinder block or something under each of their headbed, and it's probably a little weird at first, but you get used to it, and I'm sure you sleep better without heartburn. So that is something people try. Triggers, fatty foods, caffeine, chocolate, yada yada. There's lots of things that trigger, and people aren't going to be triggered across the board on the same things. But if they do know a trigger, they can possibly take something beforehand. So maybe they're going to go out and have pizza, and they know whenever they eat pizza, they get heartburn. Take a famotidine before you go out to eat, and then you get a sustained effect throughout the evening. Tight-fitting garments, I don't know if I buy this one personally. I suppose if you had something really tight around your waist, it could cause pressure that would end up causing heartburn. But again, I don't know how tight it would have to be. It seems a little, I don't know. I don't really buy that one totally. Some stuff that promotes salivation, like lozenges and gum, can help with symptoms. And then tobacco and alcohol are kind of both associated with GERD-related symptoms, and so avoiding those in general can help improve symptoms, or I guess the better way to say that would be to stop symptoms from occurring at all. So how do we treat GERD? Usually you're going to start with a lower standard dose histamine 2 blocker for 2 weeks. We always start with the H2 blockers for mild to moderate GERD. So this is somebody with less than 2 episodes a week, and that's just because, again, it works a little bit faster and it doesn't have quite as bad of long-term known side effects with it, or known potential complications, I should say. If you have persistent symptoms, or you don't meet this criteria, like more than 2 episodes a week, then you probably want to go straight to the PPI, excuse me, and you're looking to use it for 8 days. If they had really severe symptoms, then you might consider the BID dosing of the PPI, but Q-day is generally fine for most patients. Pregnant, sulcrophate, and I remember ranitidine is the recommended one in pregnancy, but again, famotidine is probably just fine. PPIs are regularly used in pregnant patients too. So pregnant patients, just like everyone else, might try an H2 blocker and just it doesn't work, so they go to the PPI after that. It's the thought of the risk of PPIs is thought to be minimal to the developing fetus, and the benefits substantial for the patient. Peptic ulcer disease, we talked about this back in ID with H. pylori. So remember that the triple therapy example is 2 weeks of proton pump inhibitor plus your 2 antibiotics, your your amoxicillin and your clarithromycin. The one thing about treating with high-dose PPIs, you do get rebound acid hypersecretion with the prolonged dosing. So considering going from 2 weeks of twice daily to maybe a couple of weeks of once daily, and then stopping or every other day or something like that. Some people will need to taper off these, and abrupt cessation can be problematic. What I would recommend is, if you didn't want to continue this, to have them use an H2 blocker as needed after you stop it, just in case they do get some of that rebound, to help transition them to not using it at all, hopefully, once the ulcer is healed. NSAID use causes mucosal damage, so we talked about this already. Dose duration, age, etc. COX-2 selective having a lower risk, but we talked about prophylactic therapy. Just to review that here, almost always going to be the proton pump inhibitor. A high-dose H2 blocker is just fine. There's no problem with that. And again, long-term NSAID use is generally recommended to be on some sort of acid-suppressing regimen. Stress ulcer prophylaxis. This is something usually associated with hospitalized patients that are immobile. So I think about like an ICU patient or somebody who's mechanically ventilated being at highest risk, or somebody who's also on some sort of anticoagulant would also be risk. It could occur quickly or take several days. Prophylaxis is indicated. Usually we use oral PPIs or IV H2 blockers. They're both pretty inexpensive choices. Oral histamine blockers are probably okay, but we usually don't use them for this reason. And IV PPIs tend to be quite expensive, so we avoid them unless we absolutely have to. If you have an upper GI bleed, acid suppression is an arm of treatment, and in fact, by increasing the pH, suppressing the acid production, we end up with a better healing environment for the ulceration. IV PPIs, pantoprazole, esomeprazole are the common ones we give. We schedule the dosing. For a while, they used to give these as a continuous infusion, but actually it was proven in a number of studies that intermittent bolus dosing is just as effective as continuous infusion. So why do we do this? Well, it raises pH, again, promotes healing, and the IV infusion can significantly raise the pH more than oral therapy. So if we give somebody a dose of IV PPI, it seems to work quite quickly versus taking 5 days like the oral therapy. Let's see, octreotide I don't really talk about too much. It's basically if you have variceal bleeding, I think about alcoholic patients get this, and it has some vasoconstriction aspects that work there too. So if you have an alcoholic patient with variceal bleeding, usually they'll use both PPI, IV, and octreotide. Combination therapy, you can really mix and match these if you want. So using antacids in addition to one of the longer acting medications is fine. PPIs and H2s can be used together. In fact, a really common regimen I see people on is they take a PPI in the morning and an H2 blocker in the evening. You just don't want to do them at the same time. Most people won't need multiple medications, and if somebody is on multiple medications, you might want to question what their symptoms are like and why and who recommended that, and have they been diagnosed with an ulcer in the past. So I think these are probably one of the most common medications that get started or recommended for different reasons and then never taken off, or the patient never gets instructed to stop the medication. It's a really common thing we see in the hospital where somebody gets on it for prophylaxis and they get discharged on the med and they just never stop it because no one ever told them to, and they really have no reason to keep taking it. So remember, the risks aren't nothing. There is that enteric risk that is probably the most common thing to remember with these medications, and we want to make sure we're avoiding that if we can.